patients with LAM have very much the same criteria for lung transplant as any other patients do. In New Zealand, we transplant adults, so anybody between the ages of 16 to 65 is eligible for lung transplant, as long as they have no other major comorbidities, and that's really no other organ system disease, no major cancers, no kidney, liver or heart disease. They have to have no major psychiatric illness and no major drug or alcohol dependency, and in New Zealand they have to be smoke-free for at least a year before we'll consider them for lung transplant. So lung transplant becomes an option for LAM patients when their FEV1 becomes around 30%, and usually when they develop significant limitations in their activities of daily living. So we would expect a patient to be referred for lung transplant assessment when their lung function falls, when they start to get breathless with activities such as showering and dressing themselves, if they perform household tasks, or simple things that they would usually have been able to do easily. The most important thing that I would want to tell a GP who had a patient about to go on the active waiting list would be that we'd be stopping their sirolimus, which would be the mainstay of their treatment for their LAM prior to transplant. And the reason that we do this is because sirolimus interferes with wound healing. And of course, once a patient's on the active waiting list, we can't predict when they'll be transplanted. So we'd probably ask them to stop it before we put it on the active waiting list, maybe 1 to 2 months before. Lung transplant recipients are matched with donors for size and blood group. So that means that any recipient can receive a donor who is blood group O, but otherwise patients are matched for blood group. So a recipient who is blood group A can have a donor who's blood group A or blood group O. A recipient who is blood group O can only have a blood group O donor. The other matching criteria is height. So essentially you need lungs that are the same size as you. Recipients and donors are not matched for gender or age. In the past, lung donors were commonly young men who had brain injuries, unfortunately from car accidents or other accidents. In more recent years, our donors' age is increasing, and it tends to be more people who have strokes or brain bleeds. So in fact, we have an increasing number of female donors and in fact smaller donors. So sometimes in the past it was our smaller patients who waited longer for donors. Now in fact some of our very tall men wait a long time for suitable donors. And of course how long you wait for a donor is very unpredictable, but our average time on the waiting list in New Zealand is around 6 months. Lung transplant for LAM is actually quite a rare indication for lung transplant, and if we look at the international figures, actually less than 1% of lung transplants are done around the world for LAM. In New Zealand we've done almost 200 transplants, and we've done 2 transplants for LAM, and I've personally been involved in one of them. In the past, women with LAM were traditionally offered either a single or a double lung transplant because patients with LAM can have a single lung transplant because they don't have any infection in their lungs. That is a possibility. But over recent years, it's become obvious from analysing the data from the International Heart-Lung Transplant Registry that women with LAM do better with a bilateral lung transplant. In New Zealand, we tend to do bilateral lung transplants on virtually all of our patients, and so most of our women with LAM who came to transplant would be young, and we would tend to do double lung transplants on them. When you look at the international data, LAM patients do have the best survival rates of almost any of the lung transplant patients, and I think this is because on the whole they're a group of women who are otherwise in excellent health, who have single organ disease and do well post-transplant. And in New Zealand we're very proud of our one LAM patient who's still alive, who's just passed her 10-year anniversary after transplant, and I believe is making the most of her lung transplant. All GPs who look after post-transplant patients are advised to give their patients annual influenza vaccinations and also to give them pneumococcal vaccinations and also to avoid infection. And it's also important that they're careful with infection after transplant, so avoiding family or friends who have infection. Patients who have transplants are also increased risk of cancer after transplant, and particularly for women who have LAM, obviously need to have regular cervical screening and regular mammography after transplant. LAM patients do have some problems that are specific to them after transplant, and those problems are chylous pleural effusions, which can require specific management with chest drains to drain them, and sometimes dietary management, sometimes even needing total parenteral nutrition for a period of time. These can usually be managed, and in fact the transplant that I've been involved in here in New Zealand, and in fact a patient with lamb that was transplanted when I did my fellowship in Australia, didn't develop chylous pleural effusions. Of course, if a lamb patient had a single lung transplant, then they might still potentially have a pneumothorax in their residual lung afterwards. Patients with lamb are still likely to have could still potentially have problems like a hemorrhage into an AML after transplant, and their GP needs to be aware of that. And of course we need to monitor their kidney function carefully, because the drugs they take for immunosuppression after transplant do put a strain on their kidneys, and we need to bear in mind that they may not have normal kidneys. I think patients with lamb are basically women who have single organ disease, and we need to remember that they should be optimising their health, that the drug sirolimus can cause them to have high cholesterols, which is a significant risk factor for cardiac disease. So especially as we may be thinking about offering these women transplant in the future, it's imperative that they manage the rest of their health, and things like not smoking, which I would think would be very unlikely, but optimising their health in other respects is very important, so that these women can be eligible for lung transplant and have the excellent outcome that they're entitled to afterwards.